A very good evening to all. I'm Dr. Uttara Mohan from the IIP Digital Media team. We are live on IIP India YouTube channel for this webinar. To tell you briefly about the digital team, we are a team of physios who handle the Zoom platform, webinar live streaming, and the social media profiles of IIP, which are available on Facebook, Instagram, Twitter, LinkedIn, and YouTube. You can follow updates of IIP and notifications about our profession on our social media, and also get updates of our events such as webinars, workshops, CMEs, conference, health camps, etc. You can subscribe to IIP India YouTube channel so that you get a notification for live webinars in future. In the YouTube channel playlist section, the webinars are segregated into folders, categories on different subjects for easy access. The links to the social media will be shared in the chat shortly. Uh, Today's webinar is on physiotherapy rehabilitation on breast cancer and overview. The speaker for today is Dr. Supriya Nakhate. This webinar is being organized by IAP Thane district team of Maharashtra. Now I request the Thane team to please take over. So, Dr. Gaurav, you can take over.
Hello everyone, myself Dr. Gaurav Tripathi. So here we welcome Dr. Supriya Nakhate. She is a senior oncophysiotherapist at ACTREC, a unit of Tata Memorial Center. She is certified lymphedema and onco rehab therapist, certified palliative rehab therapist, MPT cardiopulmonary rehabilitation, founder member of social onco physiotherapists. So I welcome you, ma'am. Please take over, ma'am.
Thank you so much for that lovely introduction. I hope I'm audible to everyone.
Yes, ma'am.
Should I start the screen sharing?
Please go ahead, ma'am.
Is my screen visible to you all?
Yes.
Okay, shall I begin?
Yes, ma'am, you can start.
Okay. So first of all, I would like to thank IAP and all the organizers of this webinar for having me here to talk on this topic. So the topic for today is physiotherapy rehabilitation on breast cancer, which is going to be an overview. So let's see what all are we going to cover in today's session. Okay. So the objective for today's session are uh, what is breast cancer, the different types of breast cancers, management strategies and the medical management strategies, the impairments seen in the breast cancer patients, what are the rehabilitation considerations, and a little just about metastatic breast cancer. So let's see what it is. So, what is breast cancer in first place? I'm sure that most of you all must be knowing about it, but I'll just throw a light on it. So it is basically a malignant tumor that starts in the cells of breast, which can grow into the surrounding tissue or it can spread to the rest of the body. It occurs mostly in women, but men can get it too. So yes, even men can have breast cancer and it is seen in some of the population, especially it is of genetic origin when it happens in men. So it is accounted for 13.5 new cancer cases and 10% cancer related deaths in 2020. So this report is based on the cancer registry, which is from India. So you all can see that every year, like 13.5 new cases of cancer are just from the breast cancer, and it accounts to about 10% of cancer related mortality. So let's move to type and stages. So on the left side picture, we can see the type of breast cancer. So over here, we can see on the left side, this is a normal breast, which comprises of the milk duct, the nipple, and these are the lobules which you can see. So there are four types of breast cancers: ductal breast cancer, lobular breast cancer, mixed breast cancer, and inflammatory breast cancer. So in ductal cancer, you all can see that basically the cancer starts in the milk ducts, as you all can see in the yellow spots which are present over here. The lobular breast cancer, as the name suggests, lobules, so it is basically present in the lobules which are located in the breast. And the mixed cancer would be a mix of the ductal and the lobular breast cancer. And inflammatory breast cancer is somewhat which is of inflammatory origin. It probably arises from the skin of the breast and would not affect the lobules or the ducts per se. So, how do we stage the breast cancer? So, as we can see in the diagram on the right side, so stage 1 breast cancer, this is an invasive tumor which is less than 2 centimeter in size, and it is basically inside the breast. As you can see, as the stage advances, which is stage 2, the tumor would be approximately 2 to 5 centimeter, and you can see in the picture that the size is little larger than the stage 1. And as we progress to stage 3, the tumor size is more than 5 centimeter, and you all can see these black dots which have crossed the breast. So basically in this stage, the cancer has started to invade the nearby lymph nodes which the breast drains. So it could be the supraclavicular or the axillary lymph nodes which mainly the breast region drains into. And stage 4, the tumor spreads to the other organs, or it is also called as metastatic breast cancer, which means that the cancer has spread to the other organs of the body. It could be brain, lungs. We are going to talk about it in the subsequent slides. So, what are the risk factors and symptoms for this? So, we are going to divide the risk factors into non-modifiable and modifiable risk factors. So, non-modifiable would be age. So, as the age advances, the risk of the breast cancer goes on increasing. The lengthy reproductive life, which means that if someone who has got a menarche at an early age and a menopause at a late age, so basically the reproductive life of that a particular woman has been for a very long period, and hence she's been exposed to the numerous hormones. So the chances for her developing breast cancers are high as compared to the other females. And family history, so we know that someone who has had a family history like the mother or sister and anyone directly related to the person has a higher chances as compared to any other person. So non-modifiable are like the age at first pregnancy, breastfeeding, obesity, like if the BMI is more than 30, if someone who has been taken hormone receptor therapy or oral contraceptives, who has been exposed to ionizing radiation, the diet is such that, and who is like the alcohol consumption is on a higher side. So definitely these uh, uh, factors which are there, the modifiable, they are called modifiable because yes, the changes can be made in this particular factors, and we can reduce the risk for breast cancers. So, what are the symptoms? So, the symptoms could be any constant pain or nipple pain in the pain in the breast or the nipple pain, an inverted nipple, rash or color on the skin around the nipple, change in the size or shape of the breast, dimpling or change in the skin texture, lump or thickening in the breast or underarm, swelling of all the part of the breast area, or unusual discharge from the nipple. So, a person or a woman having breast cancer would exhibit like any of these symptoms or even mixture of these symptoms. So, which is why it is important for us to know and also to educate them that what all the symptoms could be present if you all are suspecting breast cancer. So the medical management strategies mainly comprises of surgery, chemotherapy. Now the chemotherapy is also divided into a neoadjuvant therapy and a adjuvant therapy. So what do you mean by neoadjuvant therapy? So neoadjuvant therapy is something where the chemotherapy is given prior the surgery. So as we were seeing at the stages, so when they feel that the tumor has spread to the lymph nodes, the tumor size itself is big, So they usually give the chemotherapy before the surgery so that they can shrink the size of the tumor, and then they can operate. And later on, basis on the report, the surgery reports, they can plan the adjuvant chemotherapy and the radiation therapy. So the radiation therapy, as I said, hormone therapies. So the cancers, the breast cancers which are hormone receptive, they are called as ERPR positive. So they are estrogen receptor positive or progesterone receptor positive. So they managed by hormone therapy. So the usually given hormone therapies are tamoxifen. This is usually given in some patients, and targeted therapy. So targeted therapy, there's a drug called trastuzumab which is used. So after completion of the treatment, or these are the drugs which target specific cancer cells. So hence they are called as targeted therapy. So this is basically the line of management of breast cancer depending on the stage and the condition of the patient. So we are just going to look into surgery in detail. Why? Because this is important for us when we are rehabilitating the patient, or when the patient comes to us with some problem or some impairment. So it is important for us to know all these things so that the treatment can be planned accordingly. So we'll have a look at the surgery. So we can see that here on the left hand side, it is a primary tumor. So primary tumor, the surgery could be a mastectomy or a breast conservation surgery. So mastectomy involves the removal of the entire breast. So it could be a radical mastectomy wherein the breast tissue as well as the underlying muscles are also removed. In some cases wherein the tumor has spread to the muscle areas, but usually the radical mastectomy is not done. What is usually done is a simple mastectomy, sparing the muscles, and the breast conservation surgery. So breast conservation surgery only involves removal of the tumor and some area around it, but the breast is conserved, hence it is called as the breast conservation surgery. So when looking at the axillary lymph nodes, so this surgery is combined with the removal of the axillary lymph nodes. So now when they plan to remove the axillary lymph nodes, so this is what they usually do. So, if we can see here, node negative or node positive. So, SLNB. So, this is the sentinel lymph node biopsy. So, sentinel lymph node is the first lymph node where the cancer drains. So, what they usually do is they inject a dye into that lymph node, and they see that which lymph node is showing any color. So, they identify the sentinel lymph node and they send it for the frozen section. And if it turns out to be positive, then they progress with the further lymph node dissection. But if it turns out to be negative, then they don't progress with the further lymph node dissection. But if it is positive, so then there are two possibilities. So they either perform axillary sampling or the axillary clearance. So what is the difference between sampling and clearance? So if the lymph node removal is less than 5, so it is usually called as axillary sampling. And if it is more than 5, it is called as axillary clearance. So subsequently, you all will know that why this is important for us, because the impairments which the patients present is all dependent on the basis of the surgery or the treatment the patient is going through. So here is the list of the impairments and the complications post-treatment. So to begin with, pain, there could be decreased shoulder mobility, chest wall adhesions, lymphedema, breast edema, axillary web syndrome, chemotherapy-induced peripheral neuropathy. There could be weakness of the involved upper extremity, postural malalignment, fatigue and decreased endurance, declined lung function, and psychosocial affection. We will be focusing on each of this, especially the one which are important for us to know. So let's proceed. So what would be the rehabilitation goals? So the rehabilitation goals for us would be to improve the shoulder mobility, minimize the incidence of the lymphedema, ameliorate the symptoms of the adverse effect, to improve the cardiopulmonary function, and to improve the quality of life. So these are the goals, and how do we achieve those goals? So let us see what are the rehabilitation considerations. So first and foremost, post-operative breast class or patient education. Now, I understand that most of the people who are attending or who are practicing, patients might not be referred to them immediately post surgery. But if you all get this opportunity of seeing the patient immediately post surgery, so whenever you see the patient or whenever is the first contact with the patient, so this is what your education or the thing which you should tell the patient. So patient education would comprise if the patient is immediate post-op. So immediate care is the drain care, the wound care, and the self-image issues. So this drain care and wound care is usually given in the hospital where they are taught how to maintain hygiene of the wound, like they are supposed to have bath daily. They can clean that area also so that it doesn't land up into infection. The drain care, the drain which is given to them, they are taught to empty it every day at a particular interval so that when they come for the follow-up, proper chart is maintained so that determines whether you are ready to remove the lymph node, the drain or no. And self-image issues, so this is basically important for someone who has undergone complete breast removal. So we'll be mentioning that in the subsequent slide. So what are the lifetime care? So lifetime care would comprise of the exercises, the do's and don'ts, the arm care which they are supposed to take, the use of breast prosthesis, and self-breast examination. So let's see the exercises first. So this is the post-operative breast class session which we usually take at our center. So these these exercises are taken immediately POD 1 of the surgery, unless someone is having any complication or if someone has undergone any flap reconstruction. Only then the session is postponed for a week or so. But otherwise, all the patients are asked to come in a group and session is taken for them. So here we can see that we start with the breathing exercises, the shoulder range of motion exercises. So active assisted exercises, these exercises, assisted flexion, shoulder shrugs, retraction, and these exercises. So these are started immediately on the next day of their surgery. And the usual dose is 3 to 4 times a day and 10 repetitions each set. We usually ask them to do the ball exercise a little frequently, like as compared to the other exercises. If they are done 3 to 4 times a day, then these exercises would be ball exercise would be 4 to 5 times per day. So you all can see that why it is important to start the session immediately next day. So immediately next day we want to start because this early mobilization helps to minimize the risk of shoulder restriction. Because we know that starting with the exercise is not going to hamper the sutures. But if we just let them go like this, because they are discharged immediately, like in third day or second day itself. So if they are going to go like this, then they will be very possessive or they will be very scared to move their arm. They will think that their sutures will just give off, or the drain will get stretched if they start with any limb movement. So it is very important for us to educate them about all these things, that they can even start with the exercises and they can use their arm for their daily activities, their personal activities which they are using as much as they can depending on the pain tolerance. So the next thing which is important is the arm care. Now, why this arm care is important? So, like I mentioned before, in the surgery part, so when they are removing the axillary lymph nodes, so when the lymph nodes is removed, so what happens to the arm? So this is what is to be told to them. So in this figure, you all can see the normal lymphatic structure, and below is the one in which the lymph nodes are removed. So you all can see that there is some interruption in the flow or some impairment in the flow of the lymphatic channels after removal of the lymph node. So what happens is after removal of the lymph nodes, the chances of the lymph stasis, the chances of that person developing lymphedema increases more as compared to any other person. So, which is why we need to educate them that you need to maintain this arm care properly, because if you don't maintain this arm care properly, then the incidence will increase all the more. They are actually at a risk of developing lymphedema, and if they do not do these exercises or follow arm care, then all these things will add up to that risk and they would develop lymphedema for certain. So what are the precautions which we usually ask them to take is they're supposed to avoid any injury, avoid any infection, as in they should take care that whenever they get cuts or any injury, so they are taking care of it properly, applying band-aid or going to the doctor if it is more critical. Then avoid extreme temperature, like extreme hot and extreme cold. So in cases like if someone is used to of hot fermentation or cold fermentation, so they are supposed to avoid it on that particular extremity. And also while cooking food, if someone is not able not supposed to touch any hot object directly with that particular extremity. They are supposed to avoid any constriction on that arm. So the clothes which they are wearing, so the sleeves should be loose enough that there should be like at least 3 finger gap between the sleeves, so that there is no constriction on the lymphatics over there. Avoid any muscle strain. So they are told that they are allowed to do all the activities, but they should avoid the activities which are causing direct strain on that particular extremity. So it could be anything, like they are not supposed to lift any heavy it or any heavy object which they used to do initially, or anything which would cause direct pressure on that hand. So any yogasana or anything which is causing direct pressure on that hand is to be avoided. Keep the skin well hydrated. So, because if the skin is not hydrated, then the chances of infection to that skin increases. So, this is the general arm care which is told to the patient, so that if you all maintain this arm care properly, the chances of lymphedema are lowered as compared to the other patients. So, the do's and don'ts which I mentioned above. So, basically, if anyone is having cuts and all to clean the cuts. They can wear gloves while doing something which they feel that they might just injure. These are the thimbles. If someone is doing any stitching work, they can use it. Apply insect repellents and sunscreens to protect the skin if someone is having mosquitoes, and also they are not supposed to scratch. And yes, they are not supposed to do waxing or use a razor. So hence, if someone who is young, so they are supposed to use electric shavers or hair removal cream. So this is what they're supposed to do. And what are the don'ts? So they are not supposed to check the BP on the same arm, any injection or blood test from the same, or tight clothing and jewelry, as I mentioned, in the same arm. And repetitive and vigorous movements are to be avoided for that particular extremity. So the next thing to be educated or counseled about is breast prosthesis. Now, why breast prosthesis is important, and this is especially in the patients who have undergone complete breast removal or a mastectomy. So what happens when a mastectomy is done? So there is asymmetry of the trunk and abnormal scapular alignment, which could result in the lateral weight shift in particularly large breast women. But it can happen to medium to large also, and this usually causes a postural malalignment. So as you all can see here, so there are cotton processes also, and there are silicone processes also. So these processes are usually given to the patient after the suture removal, after their sutures are healed properly. So this is when they are given the processes and they are taught how they are supposed to wear. And in some cases, like some patients who are young, they even do a breast reconstruction surgery. So at times it is even done simultaneously at the time of the cancer removal and the reconstruction, or it can be done later on also. So this depends on the surgeon and the patient's discussion. So this is important. The next thing is self-breast examination. So this is important because now, if someone has got or developed cancer in one breast, so it is important for them that to now develop a routine so that they are keeping a check on their other breast also, so that they understand or they recognize the symptoms very early, and they can report it to the doctor, and the treatment would be effective in that particular case, or they would not suffer that much. So hence it is important to educate them about the self-breast examination. So self-breast examination is usually done.
Hi, sir.
Is,
बोल ना.
is, u-
बोल ना.
is usually done once a month. So it is basically scheduled on the basis of the menses, like you usually do 10 days or 7 days after the menses. So this is how it is educated to them. And if they have undergone breast conservation surgery, so after that site is completely healed. So after a month or so, they can start with the breast examination on that side also. And in case of mastectomy, on the other side. So yes. So next important thing is the pain. So the pain, neuropathic pain following breast surgery. So the different types of pain what we can see following breast surgery is, so there is a phantom breast pain. So phantom, as you all know, it is a sensory experience that the removed breast is still present and it could be painful. The next could be intercostal brachial neuralgia. It mainly causes it is seen in the mastectomy patients, because in mastectomy there is incision over the chest wall, so hence it causes the involvement of the intercostal brachial nerve, thereby leading to the intercostal brachial neuralgia, where the pain is accompanied by sensory changes in the distribution of the intercostal brachial nerve. So the patient would complain of some sensory changes on the inner aspect of the arm. So it could be pain, or at times the patient complains of paresthesia or numbness also over there following breast cancer surgery. So this is with or without the axillary dissection. The next type of pain is neuroma or the scar pain. So the pain in the region of the scar on the breast, chest, or the arm that is provoked or exacerbated by percussion. So it is this pain or immediate post-operative pain, as we all know that it is just because of the surgery and the sutures which are healing. And the other nerve injury pain could be pain outside the distribution of the intercostal brachial nerve, consistent with the damage to the other nerves during breast cancer surgery. It could be medial lateral pectoral nerve, long thoracic or thoracodorsal nerve, the other intercostal nerve, because the area which is handled comprises of many nerve tissues. So hence, injury or handling of these tissues is much more common in breast cancer patients. Um, so the other causes of pain could be the neuropathic pain caused by the tumor recurrence, chemotherapy associated neuropathy, and radiation plexitis or plexopathy. So if someone has received radiation to the chest wall post breast cancer surgery, so then because of the inflammation and then later on fibrosis of the nerve tissue, so the radiation plexitis or plexopathy can happen in these patients also. So, what could be the assessment and the treatment of pain? So, we have different pain assessment tools. To assess the intensity of the pain, so they can be done. There are pain questionnaires also which can be used, and most important thing is to determine what is the cause of the pain, because until and unless you know what is the cause of the pain, the treatment won't be planned accordingly. So if the pain is because of the if there is any tumor recurrence that is happening, then definitely it is not in our domain. Yes, if it is because of the other reasons which have been mentioned prior, so then they are manageable by a rehab specialist. So the treatment could be a pharmacological management. The non-pharmacological management comprises of the exercises, TENS, and desensitization techniques. So what is chemotherapy-induced peripheral neuropathy? So I believe that most of the breast patients whom you all must have encountered or who have visited your clinics, they must have told you that they have this altered sensation or paresthesia in their hand, in their feet. So what is this? So this is basically a chemotherapy-induced peripheral neuropathy. So there are certain chemotherapy agents which are responsible for this particular symptoms. So it is prevalent in 68% of the patients in first month following the chemotherapy, and 30% after the 3 months. So the incidence, as you all can see, can range from 30 to 60%. Now, what are the factors that contribute? So it is first that which chemotherapy drug was administered. the doses which were given to the patient, the cumulative dose exposure, and other factors. Like suppose who is elderly, who is having diabetes. So in these cases, already the blood supply or the vascular supply to the nerve is compromised, and when they are administered chemotherapy, so this just adds on to the risk of developing peripheral neuropathy. So this is it. So what are the signs and symptoms? So the signs and symptoms could be paresthesia or dysesthesia. There could be altered proprioception. Yes, some patients do complain of loss of balance, like they are not able to stand. They experience swaying and all. So these are the, like in extreme cases, they do complain of it. Autonomic disturbances are usually rare, and motor weaknesses are very, very rare in these patients. They usually present with sensory complaints. So, how do we differentiate CIPN from other neuropathy? So, the distinguishing factors are it will be symmetrical. So, you will not see it in one hand, it will be symmetrical, and mostly it will be in bilateral hand and bilateral field. So, the intensity might vary, but they will be present in both the limbs, and it is distal and length dependent, like the it could be after the exposure of the chemotherapy only. It is predominantly sensory, and it is after the administration of the chemotherapy drugs, early or costing effect. Costing effect means the cumulative effect of the doses which have been administered. All of them don't exhibit these symptoms immediately after their first chemo or second chemo. Even some of them experience after the chemo is done. So it depends from patient to patient. But yes, making a note of these symptoms are important, because when we are treating a patient, we are not treating that one thing. We need to treat that patient holistically so that the quality of life is improved. So, management would comprise of the sensory retraining, balance and proprioceptive training, strength training, gait training, and use of assistive devices. Like if someone is having a fall, so assistive device can help in reducing the risk of fall, and also in reducing or minimizing the energy expenditure in those patients. Yes. So the next problem is the impairment would be scarring of incision or movement restriction. So this usually happens post-surgery. So the surgery incision would tend to get adhered, or thereby the patient would not be able to do the shoulder mobility as much as the patient was doing earlier. So there is limited shoulder mobility. So limited shoulder mobility would thereby cause the frozen shoulder in long run. So the treatment would comprise of scar mobilization. So it is important to note that if the patient has received radiation, then the scar mobilization is not to be done immediately over the irradiated area. You need to at least wait for 3 to 4 weeks and then inspect the skin. If the skin is normal, if the patient is not having any dermatitis or any sort of changes on the skin post radiation, then only you can begin with it. But yes, you can start with the active assisted exercises, gradual stretching, and shoulder mobilization. So these are the patients mostly who are scarring doesn't happen in everyone. It happens in certain, like who have initiated the exercises late, or because of the flap surgery, or because of some issues, they were not able to start the exercises immediately, or some who were not educated about it, or someone who are having a tendency to develop this. This problem is basically seen in those patients. So the next important complaint or the important impairment which we see in these patients is axillary web syndrome. So what is axillary web syndrome? It is also called as lymphatic cording. So it refers to a rope-like structure that develops mainly under the axilla, but it can extend to involve the middle aspect of the ipsilateral arm down to the antecubital fossa. So it can start in the axilla, it can run from the antecubital fossa, and at times it is even seen in the forearm. So there is a visible palpable cord of the tissue that is made taut painful by shoulder abduction. So what happens is, if you ask the patient to do shoulder abduction, so the patient will suddenly go into elbow flexion because he is not able to maintain this position. There is a taut band over here. So this is visible, and in certain cases, if it is not visible, then when you palpate over there, the anterior cubital fossa up till the forearm and the axilla, so you will see a cord-like structure over there. So it is usually palpated with 2 or 3 fingers. So you run your hands across like this and you can feel. So there is a string-like structure which you can feel, and it is different as compared to the other tissue. So why this basically happens? So this is basically because of the disruption of the normal lymphatic drainage channel that occurs during the lymph node dissection. So what happens is this leads to lymph stasis, and this stasis gives rise to protein-rich exudate into the interstitium, which can later on become fibrotic. So there is fibrosis. There could be fibrosis of the lymphatics itself and the surrounding structure of the lymphatics post lymph node dissection. So it can be seen even in the patients who have undergone minimal lymph node dissection also. So it is not always necessary that person having more lymph node dissection would develop. But yes, the risk is directly proportional to someone who has undergone more axillary area handling or more lymph node removal. So their chances of developing axillary web syndrome is more as compared to the other patients. And uh, it usually is seen in 6 to 8% of 86% of the patient. It appears as early as 2 to 8 weeks post surgery, and it may persist for years. So this is basically a self-limiting condition. If you don't treat, it is going to reduce. But if you don't treat, then the patient are in pain. The patient are not able to move their arm. They have restricted ADL, so all these things are there. So hence you need to intervene or treat this problem as early as possible. So you all can see in this picture. So the below pictures you all can see that the cord is starting in the axilla, and then from the axilla it is progressing to the arm and then to the cubital fossa, and it is even going into the forearm. So some do have these extensive coding also, and in certain cases there could be coding even in the chest wall also. So this depends from patient to patient and the type of surgery which the patient has undergone. So what is the treatment? So the treatment, first place, educating the patient regarding AWS. So now most of the patients, what they think is like after the surgery, they were doing exercises, they were able to gain their pre-surgery mobility. So all of a sudden, what happens is that the mobility gets reduced and they are having this tremendous pain. So they are not able to understand that they were fine all the while and now what is happening to them. So it is important to tell them that this is usually a complication which is seen in such surgeries, and you need not worry about it and it can be taken care of. So how should you manage this? So there are manual techniques, skin traction,
As
there
usual.
are manipulations. There is some disturbance. Hooking manipulations, like these are the techniques to break the coding. You can apply moist heat to the cord. As it was told that yes, like hot fermentation and everything is not allowed. But in these patients who are having cords, so you can give a extra padding to the hot fermentation bag or whatever means you are using. Like extra padding is provided, and it is given for 5 to 10 minutes. So that is sufficient. And after that, you can do the maneuvers. So gentle, passive, or active range of motion exercises, even neural tissue mobilization techniques can be used in these patients. They really work well in these patients. So the next important thing is breast edema. So breast edema is basically seen in the patients who have undergone breast conservation surgery. So the usual protocol for a breast conservation surgery is chemo or radiation, after the surgery. So radiation is given to most of the patients who have undergone breast conservation surgery. So here we can see the causes. So it could be axillary lymph node dissection, radiation boost on the tumor bed. There could be locoregional RT, oncoplastic surgery which has happened. So the symptoms could be increase in the breast pain. Initially, the patient would present with pain or just mild heaviness, and it usually affects the quality of life as the body image is also affected. So you can see in the picture that the left side breast looks huge as compared to the other side. So this is usually like the patient is not able to understand what it is, and the quality of life is also affected by it. So what are the management strategies? So we have this breast manual lymphatic drainage which we teach the patients, and we do it for a few sessions in the hospital itself, and later on it is taught to the patient. The use of proper fitting breast support is important, and a compression garment. So this again depends on the staging of the breast edema. So at times, if the breast edema is not at a very extensive stage or a higher stage, then it can be taken care with the manual lymphatic drainage or by the use of a proper breast support. But in extreme cases, a compression garment might be needed. So this is depending on the subsequent visits of the patient, follow-ups of the patient, you can determine it accordingly. So after breast edema, we have lymphedema. So this is breast cancer related lymphedema. So what is lymphedema? So this entirely is a different topic itself. Like a lot can be talk on this topic, but I will just try to mention in brief. So lymphedema can be defined as accumulation of protein-rich fluid in excess in any body part that has experienced damage to the lymphatic system. So as I have mentioned before, so anyone or the patients who have undergone a lymph node removal surgery, so their lymphatic system is already at a compromise, and hence they are at the risk of developing this particular symptom. So the incidence of breast cancer lymphedema is up to 41%. So you all can see the number that it is 41%. And it occurs due to lymph node dissection because of the radiation. So initially when they used to radiate the axilla also, now the axillary radiation has reduced in most of the places. But initially when they used to radiate the axilla also, so that used to add on the lymphatic compromise, and hence the lymphedema occurrence as well, and high BMI. So high BMI is also a precursor or something which could contribute to the lymphedema development. And most of the cases, it is poorly recognized and managed. Now, what happens is when patients, we tell the patients or patients are educated that this sort of swelling can be seen in your arm. So if it is seen, then you all should report to us immediately. But when they report to the surgeon, most of them or to any other healthcare provider, so it is told that this is something which is normal and it is part and parcel of the treatment. Yes, it is. It can happen. But first and foremost, you should try to prevent the lymphedema occurrence. And if it has occurred, you should try to intervene it as early as possible because it has stages. If you don't intervene it immediately, then it might progress to a stage wherein you are not able to effectively manage the patient. So you can see in the picture over here. So picture above, the arm is swollen, but the integrity of the skin or the shape of the skin of the arm is still better. Like it is just swollen, but it looks better. But in the picture below, you all can see, just look at the normal hand, and then you have a look at the lymphedema hand. The entire skin, the skin looks so rough. There are like skin color changes which you all can see intermittently. Just look at the fingers. How do they look? So this can happen if you don't intervene the patient timely, and it is important for you to educate them accordingly. So, what are the risk factors for lymphedema? As I mentioned before, it could be the type of the surgery, radiation therapy, the BMI, age, drain or wound complications, coding, any seroma formation post surgery, advanced cancer. So, if someone has metastatic cancer. So metastatic cancer has involvement of the lymph nodes. So because the lymph nodes are also involved because of the cancer, they are not able to drain the circulation properly and hence lead to the development of lymphedema. Recurrent infection again challenges the lymphatic system, and the lymphatic system which is compromised is not able to tackle this problem, which leads to infection. So any skin infection. So which is why when we were mentioning about arm care, why the skincare part is important. Like depending on the season, when it is winters, you are supposed to apply proper moisturizer. When it is summers, you should take care of your hygiene, because just as your body has immunity, the arm also has an immunity now, which has compromised after the lymph node removal. So you should take care of that arm so that it doesn't lead any infection, cause any infection, and increases the risk for lymphedema. And trauma is another. So any cuts or injuries again pose the risk for lymphedema. So the assessment. So there are different systems for assessment. There are birth assessments, volumetric assessments. We have BIS, bioimpedance testing, perimetry is there. So there are different equipments and different techniques through which you can assess the lymphedema. Then there is a grading system. You classify the lymphedema, and on the basis of that, you decide that what treatment you are going to plan for that patient. Discussing everything in this particular workshop, in this particular session would be a little difficult. So yes, so as I have mentioned, management of lymphedema, so conservative management can be done. And this is a complex or a complete decongestive treatment. So as you all can see here, it comprises of the skincare, manual lymphatic drainage, and the compression therapy. Compression therapy in the form of MLLB, which is multi-layer bandaging, intermittent pneumatic compression, compression sleeves, exercise, psychological care, and surgical management. Uh, Surgical management, recently they have started with lymphovenous anastomosis. So in someone who is having refractory lymphedema, these surgeries are happening at some places. But yes, the still the mainstay management of lymphedema is like complete decongestive treatment. So this itself requires another workshop or a session, because this cannot be just told, but you need to understand that how it works, and skills are required for this. So yes, another problem is decreased functional capacity. So, what are the factors which could contribute to the reduced capacity? So, the treatment related adverse effects. So, if any person who has been administered chemotherapy before the surgery, after the surgery, so they are bound to be more weak as compared to the other person who has just undergone radiation. And it also depends on the age and the other comorbidities. So, all these things they cause reduced mobility in them and decrease in the functional capacity and affection of the ADL. And this adds to the increased fatigue and emotional lability. So, what are the exercise recommendations during and after the treatment? So, even if the patient is undergoing chemotherapy, still the patient can undergo exercises with this particular program. So usually the intensity could vary from 60 to 80% of the HR max or RPE of 11 to 14. The duration of at least 20 to 30 minutes. Now, someone who is very weak and is not able to do this, so short bouts adding up to the whole in deconditioned patient is should be incorporated. So frequency would be 3 to 5 times per week. But if someone who is very deconditioned and requires lower intensity, then they can be done on daily basis. So aerobic and resistance training can be involved. So what are the things that should be avoided? So, if a patient is undergoing chemotherapy or has just finished chemotherapy, so exercising in open environment should be avoided. Exercises like swimming should be avoided during chemotherapy, so just to prevent from any infection. So, another important thing is declined lung function. Now, this could not be seen in most of them, but yes, someone who has undergone radiation, because they receive radiation directly to the chest wall, so the chances of them developing radiation-induced pneumonitis and later on lung fibrosis can be seen in some of the patients. Now there are different techniques, the radiation techniques which have come up, which reduce the toxicity of the lung. So hence these complications have reduced. But yes, it can occur in some of the patients, and especially if someone who already has some pulmonary comorbidity. So these chances are much more. Like even if a slightest of the affection or the lung toxicity can cause their decline in the lung function, and they could be symptomatic for it. So the management usually comprises of the symptomatic relief and the pulmonary rehabilitation. So now we move on to metastatic breast cancer. So what is metastatic breast cancer? So as I mentioned in the staging for breast cancer, I had already mentioned that a cancer which has spread beyond the lymph nodes and through the lymphatic channels, it has spread to rest of the body. So breast cancer usually can be metastasized to bone, brain, liver, and lung. So, what are the symptoms which they can present with? So, if someone who is having bony metastasis, they can have pain. They are at risk of pathological fractures. Brain metastasis, depending on the site where the metastasis is, they have seizures or falls if the cerebellum is involved. Liver metastasis, it could lead to jaundice or uh, coagulation disorders, and lung metastasis, it could cause dyspnea, pleural effusion. So these are the symptoms depending where the metastasis has occurred. So what will be your management in them? So now we know that these probably the intent of cure or the intent of treatment in these patients is not basically to cure but to palliate. So even the rehabilitation also shifts from like management towards palliation. So symptoms depend on the site of the metastasis. So rehabilitation is mainly intended towards palliating of the symptoms. So if someone who is having dyspnea, so now you know that you should teach them the dyspnea relieving positions or energy conservation techniques. So all these things or any environmental modifications which you want to make them. So fatigue management strategies, dyspnea relieving position, prevention of pathological fractures. So this could be done by giving any assistive device so that the weight bearing is reduced on that particular area, especially if it is hip, acetabulum, such thing. And if it is spine, then a brace belt is given to them so that whenever the patient is mobile and the patient is sitting, the load on the spine is reduced, and hence the reduction of pathological fractures. And in patients who are having heavy lymph node metastasis, who develop lymphedema. So there is palliative lymphedema management also, which can be done for these patients. So, so because of all these things, what affects them is psychological and social effect, psychologically and socially. So what and how are they affected? So first is fear, shock, disbelief, hopelessness. So any patient, like be it breast cancer or anybody, so the first news which comes to them that they have been detected with cancer. So this itself is very traumatizing and very shocking for the patient. So they usually find it difficult to come terms with it, especially after the treatment, who have undergone mastectomy. So they face these body image issues. They feel that they are not being loved anymore. So most of them are being rejected by their spouses. They feel that they don't have any more role in the family. So all these problems the patient come up with. So you all need to understand this. So probably you all might not understand this immediately, but as in when the patient is coming to you is the following up. So when you just have a word, when you talk to the patient, when you are taking history, when you are asking about the other things, so these are the symptoms which the patient slowly bring up to you, and even you tend to notice. So the management usually comprises of the support groups. So support groups are there for different cancer types. So you can ask the patient to enroll themselves in it. There are group therapy sessions. So like we had mentioned in the previous slides. So we usually take the post-operative session in group. So why this group is important? It is important for them to know that they are not alone. There are other people also who are suffering from a similar problem, and you need not be anxious about it that you are the only one. So just like other patients are also doing it, even you can do it and you will be able to come over it. So this is to be given caregiver counseling and education. So now this, what happens is, now caregiver could be in both the extremes. Like some are very much caring, like they don't allow to do anything, and someone are like they don't understand that what is happening. So even their counseling and education is important so that they can help their relatives accordingly, and timely referral to the specialist when you figure that the things are going beyond management. So it is always, this can be resorted. So yes, summarizing everything. So breast cancer is one of the commonest cancer in women. Proper and timely patient counseling can help minimizing the adverse effects. Working as a team assist in early referral from the oncologist, thereby leading to effective management. So if you all have a word with the oncologist, so you all tell them that why these things are important. And when they start referring the patients fast, so the complications which happen in them, so they can be addressed early and they can be even minimized to a certain extent. Thorough knowledge of adjuvant or neoadjuvant treatment is needed in order to plan the treatment. So like I mentioned before, you need to understand that what the patient has undergone, what the treatment plan was. So you understand that symptoms which the patient is presenting is coming from where, can plan the treatment accordingly. So yes, now this is a test for myself only to understand if I was able to deliver my talk and make you all understand it properly. Uh, so if you all are able to answer in the chat, so can you all please answer these few questions? Could you please enlist some of the adverse effects post breast cancer? Good. Lymphedema. Anything else? Great. Nice. Okay. Feels like I was able to at least make you all aware of these impairments. Nice.
Ma'am, there
Okay.
are a few questions
Yes,
by
yes,
the
yes.
audience.
I am just done. Just okay. So yes, this you all have already answered that what is the arm swelling. So can anybody tell me whether this is a primary lymphedema or a secondary lymphedema? Yes. So So basically, this is a secondary lymphedema because it has occurred because of the damage to the lymph nodes which has happened. So it can't be primary. For primary, there has to be inborn or some impairment with the lymphatic system from beginning, uh, not after the treatment or after any surgery. Okay, now one last. Okay. Which treatment can lead to decline lung function in these patients? This is the last question. I had just mentioned that one particular treatment could cause decline lung function in them. Yes. So it is radiation therapy. Thank you so much, guys. I feel that all were attentive and I was able to at least give you an insight to this topic. Okay, just a minute. Okay. So, to conclude, rehabilitation means making a patient into a person again, someone who feels not only wanted and respected, but once again useful and creative. This is the heart of rehabilitation. So, we have the Society of Oncophysiotherapists. So, where we keep on posting about CMEs, we have mentioned certain training videos, certain workshop videos certain case studies which could be of help to you all when you all are addressing these patients. So this is just details if you all want to get in touch with us. And yes, thank you for your patience, and I'm ready to take the questions.
Okay, that was a very informative presentation. Thanks for that. Let us take a few questions which were asked on this. So, first one is
Can I stop sharing?
yes, yes. The first question is: does the physiotherapy rehab in these cases vary as per age? Please elaborate.
Okay, so this is a very generalized question. With age, I wouldn't say with age per se, but you should look into the problem which the patient is presenting with. So if someone who is having shoulder restriction, so the management, like if you're using any mobilization techniques, and if the patient is very frail, so definitely those techniques or the treatment methods or the modalities which you are resorting to, they might vary little bit. But yes, on generalized basis, like if the patient is having lymphedema, I would give the same lymphedema treatment for the aged patient as well as for someone who is of middle age or younger. So, and there are other considerations in aged. So, if they are having other comorbidities, cardiac comorbidities, pulmonary comorbidities, then these should be taken into consideration while you are planning a rehab program for them.
Okay, great. I hope that helps with the questioner to understand. The second question is axillary web syndrome. Is it seen in any other diseases?
Not other diseases. So at times in melanoma patients, so they have these for treatment purposes or for examination purposes, they handle the axilla in some of the patients. So it is seen in them also. So you all try to understand the pathophysiology, that it is because of handling of the axilla and the areas of the soft tissues around it, which usually lead to this problem. So if someone who has undergone that problem or that treatment is at a higher risk of developing it.
Okay, thank you. The last question is, what is the myofascial release in these cases? Breast
Okay.
cancer case. Somebody is
Okay.
asking.
So the myofascial releases which you use for the other like muscles, like normal the perpendicular massage or the kneading, it can be used, but the pressure which you are applying should be graded when you are using it for the axillary web syndrome, because the lymphatics are very superficial to the skin. So if you go like very deep inside, so that is not going to work. So yes, the techniques will work. The neural mobilization techniques work because there is fibrosis around the nerve tissue as well. So, and be mindful that you don't use one technique. Axillary web syndrome is to be managed by 2, 3 techniques together. Only MFR or only exercises would not relieve it. You need to combine these treatment modalities so that you give patients better results.
Great, great. So I would ask your permission, and I would ask Dr. Bharti ma'am, Secretary of Maharashtra State. She wants to speak a few words and share her views on this presentation. Bharti ma'am, please, over to you.
Good evening, everyone. Am I audible?
Yes, ma'am. Yes,
Am I
ma'am.
audible?
Yes.
Wishing you all healthy and happy Women's Day. And thanks to our speaker, Supriya ma'am. And must appreciate the efforts taken by our Thane team, who has taken a lot of efforts to take this webinar and make it a grand success. So congratulations to you all. I just wanted to share few things on this special topic, which is need of an hour, of course. And fortunately happened that we had a camp yesterday and talk arranged by myself, one of my friend, she's a surgeon, And it so happened we collaborated and conducted health talk and on occasion of Women's Day, and the topic covered was fortunately the same, breast cancer and cervical cancer, which are most neglected and not known by many of the women's. And if detected early and if taken care, definitely could help a lot of us. So, but yet again, the same challenge we faced. And while talking to her, even I came to know that a lot of women's neglect and to give knowledge on that, women doesn't want to listen to it because they feel that we are not suffering. Why should we listen to it? And Dr. Supriya, one more thing I want to highlight is, can we associate or can we tell all these surgeons or breast cancer surgeon, or I don't think many of them know this specialty where physio have reached to this sky level. And when it happened that we were speaking, because they refer it for later stages, and definitely patient come to us, but they are not referred immediately, or many of the surgeon doesn't know about it. Maybe you are in a hospital where they refer because they know the treatment being given. Why can't we do some awareness and some webinars or some kind of panel discussion with them, so that this could spread a wide, and many of our colleagues could help and help the patient in a better way and reach to a multi-level treatment. This would be one of my suggestion. And I would like to thanks to you for taking this challenge. I know a lot of hurdles were there for you also to start this, but thanks for accepting invitation and briefing us. I was listening to it. You had really worked hard and explained in a from bottom to top in a basic way and very simple way and very crisp way. Thanks for your explanation. I think a lot of us have got enlightened with this beautiful topic, and this is need of an hour. So once again, thank you to everyone and wish you all happy International Women's Day on behalf of Maharashtra State IAP. Thank you.
Thank you, ma'am. Thank
So much.
Any collaboration or any help from our end, we are always there, Dr. Supriya. Just approach to us. We are there. Any kind of future hands-on, anything you want, workshop or something, definitely let's do it and let's spread this knowledge wide. Because I found you are filled with a lot of knowledge on it. So definitely it should spread to many of us. Thank you.
Thank you so much, ma'am.
Thank you. Over to you, Suraj. Dr. Suraj.
Yes. Thank you, ma'am. Thank you for your kind words. And definitely, Dr. Supriya must have got all the motivational push to do more and more in this field. That's what our beloved Bharti ma'am always does. She pushes the potential and she brings out the best out of all of us. Thank you, ma'am. Thank you, Bharti. So I would move ahead to the vote of thanks for this event. So on behalf of Thane District IIP team, I would like to extend our heartfelt gratitude to Dr. Supriya Nakhate for sharing her valuable insights on physiotherapy rehabilitation on breast cancer. Your expertise and passion for the subject have been truly inspiring, and we are sure that attendees have gained a lot from your presentation. We are especially grateful to you that you could join us at the last minute with your flexibility, willingness, and to share your knowledge with us. Truly appreciated, ma'am. We would also like to express our sincere appreciation to IAP Digital team, Dr. Uttara Mohan, ma'am. She's always there as a backbone for any webinar. Our sincere gratitude to the central team of IAP and Maharashtra State team for their constant guidance and support. Your encouragement and expertise have been invaluable to us, and we are grateful for the opportunity to learn and grow together. We would also like to thank our attendees, the participants. Without them, it was not possible, for participating in today's webinar and making it a great success. Thank you once again, and we look forward to organizing more such informative webinars in the future. Thanks a lot. Thank you, one and all.
Dr. Suraj, I think participants are asking, can we get certificate? Definitely, they will be given certificate.
Yes.
So you can inform them, and to Supriya ma'am also will be providing a certificate as a resource person.
Yes. So I guess that all the participants who are still there, we have noted down all the names, and we are going to mail you the certificates, the e-certificate of this webinar. And Supriya ma'am, you will also get your resource person certificate soon. Okay, so I think that's it for the event. I would declare that the webinar is over for the day. Thank you so much, everyone. We can leave the Zoom meeting now. Thank you.
Thank
Bye-bye.
you, everyone. Bye. Good night. Bye.
Good night, everyone. Good night. Bye-bye.